Imagine a patient bursts through the ER doors, clutching their chest, their heart racing at a terrifying 200 beats per minute, right? It's intense. Well, today in this explainer, we're going to act as ECG detectives to demystify exactly what is happening inside that heart during supraventricular tachycardia, or SVT. Now, for those of us staring at these tracings, the squiggles can sometimes look like, well, absolute chaos. So to keep our focus razor sharp, you'll notice we're keeping things super clean today. Pure white backgrounds, beautiful crisp illustrations, and just a tiny spot for the logo down in the corner. No distractions, just the fascinating anatomy at play.
Here is our roadmap for today. We're going to systematically break down the SVT tracing by looking at the runaway heartbeat, decoding that narrow QRS, solving the missing P-wave mystery, deciphering ST and T-wave changes, and finally, looking at the post-tachycardia reset.
All right, let's dive right into part one, the runaway heartbeat. When you pull up an SVT ECG, the hallmark feature that literally jumps off the page is the sheer speed of the ventricular rate. We are talking about a heart firing anywhere between 150 and 250 beats per minute. That is up to 4 beats every single second. And if you look closely at the tracing, you're going to notice highly regular RR intervals. There is almost zero variation here. We're talking usually less than 10 milliseconds of difference from beat to beat. This extreme regularity, that's your first major clue, and it's absolutely crucial for distinguishing SVT from the irregular, all-over-the-place chaos of something like AFib. And this illustrates brilliantly why the heart is racing like that. Normally, as you know, your SA node is the pacemaker, right? It sets a nice steady rhythm of 60 to 100 beats per minute. But in SVT, that normal SA node gets completely hijacked by a faster race car on the track, an abnormal re-entry circuit. Think of it as this tiny, hyperactive electrical loop. If that track takes exactly 300 milliseconds to complete one single revolution, well, just do the math. 60,000 milliseconds in a minute divided by a 300 millisecond cycle mathematically forces a 200 beat per minute heart rate. It's not random, it's literally a mathematical certainty driving that rhythm.
Moving on to part 2, decoding the narrow QRS.
So despite that runaway rhythm happening upstairs in the atria, you'll almost always see a narrow QRS complex of less than 120 milliseconds. What this means is that even though the electrical signal is originating abnormally from above the ventricles, which, is literally what supraventricular means, the ventricles themselves are just quietly following orders.
This narrow shape is a huge deal. It tells us the electrical impulses is still traveling exactly where it should, down the normal high-speed His-Purkinje conduction pathway. The signal hits the AV node, zooms down the His bundle into the bundle branches, and finishes up in the Purkinje fibers. Because those fibers conduct impulses incredibly fast, like 2 to 4 meters per second fast, they depolarize the massive ventricles simultaneously and rapidly. Essentially, a narrow QRS is the heart's way of telling you, hey, the primary downward wiring is still perfectly intact. It's kind of like having a perfectly clear main highway, even if the on-ramp is experiencing total gridlock and chaos.
Let's tackle part 3, the missing P-wave mystery.
Picture this. You're holding that printout in your hands, scanning the rhythm, and you might naturally ask yourself, wait, where on earth did the P-wave go? Normally, we're looking for that nice little atrial bump right before every tall ventricular spike. But in a lot of SVT tracings, it's just completely MIA. Here's the secret. In the most common type of SVT, which is AVNRT, the impulse travels up into the atria and down into the ventricles at the exact same time. Now keep in mind, the ventricles are these massive, thick muscle walls, while the atria are much smaller. So when they fire simultaneously, the massive electrical force of the ventricles just swallows the tiny atrial P-wave whole. It gets entirely buried inside the QRS complex. But hey, we're detectives, right? We don't just shrug and accept a missing signal. To hunt down these hidden blips, clinicians look at the RP interval. That measures the distance from the beginning of the QRS complex to the beginning of the P-wave. It's essentially the time gap between the ventricles activating and the atria activating. Looking at this lets us categorize the arrhythmia into distinct groups. A short RP means the atria activate almost immediately after the ventricles, returning that electrical echo incredibly fast. On the flip side, a long RP means retrograde conduction is happening much slower, and the atria are really taking their sweet time to activate.
And if you know exactly where to look, you can spot the clues of that backwards atrial depolarization. That retrograde signal spreading backwards can actually disguise itself as tiny upward deflections, what we call pseudo R' waves, tucked at the very end of the QRS in lead V1. Or it might cause negative deflections, pseudo-S waves, masquerading at the end of the QRS complex in the inferior leads like II, I3, and AVF. It looks like it's just part of the QRS, but nope, that is your missing P wave in a very clever disguise.
Okay, part 4, deciphering ST and T waves.
You will frequently see diffuse ST segment depression and flattened T waves during an SVT episode. Honestly, it's super easy to look at that and immediately assume, oh man, a heart attack is occurring. But rest assured, these are usually just symptoms of a really tired, rapidly beating heart, rather than a true ischemic event. The rapid rate shortens the diastolic resting phase, which reduces the time for coronary perfusion, while simultaneously driving up the heart's oxygen demand. Plus, at 200 beats per minute, the T waves physically overlap with the following QRS complexes, which causes some extreme baseline distortion.
This is exactly why you shouldn't panic when you see SD depression in this specific context. As you can see here, the rapid rate is just shortening diastole and artificially distorting our baseline. It's often just a temporary, functional ischemia that resolves once the rate slows down.
Which brings us to our final stop, part 5, the post-tachycardia ECG.
Following a successful intervention, whether that's through a vagal maneuver or slamming some adenosine, the ECG abruptly snaps back to a normal sinus rhythm of 60 to 100 beats per minute. It's incredibly satisfying to watch. Those missing normal P waves suddenly reappear right where they belong, just before the QRS. And those alarming rate-related ST distortions, they slowly vanish over the next several minutes. This sudden transition is the absolute hallmark of breaking that abnormal re-entry circuit.
To wrap up our investigation today, let's connect all the dots we just talked about. Every single squiggle and abnormality ties directly back to a very specific mechanical and electrical reality inside the heart. The 150 to 250 heart rate, that's the rapid circuit itself. The narrow QRS proves the primary downward wiring is working perfectly. The pseudo-R prime, just that backwards P wave hiding in plain sight. Everything we see has a perfectly logical electrophysiological explanation.
It really makes you wonder, doesn't it? If a simple ECG can act as a real-time window into the microscopic electrical pathways of the heart, allowing us to see these invisible loops and circuits with such mathematical precision, what other hidden physiological mysteries of the human body are we just beginning to decode?